Hey, Jeremy, what's up?
Hey, Steve. I'm just looking for my recent blood work I just had done to see my A1c result, and oh, here it is. It's 6.3.
Wow, that's the lowest you've ever had.
That's,
Congratulations.
thank you.
What's your blood pressure doing these days?
Huh?
Blood pressure.
Oh, I don't know. Let me see here. Oh, 180 over 110.
Jeremy, that's high. Let your doctor know what's going on. You know, high blood pressure is going to mess up your heart, cause kidney damage, even makes retinopathy worse. And it's a silent killer. You don't feel that bad with high blood pressure. Hey, you can't be eating a stick of butter. Your blood pressure's already high. That'll raise your cholesterol and that'll really mess you up. Listen, I'm going to give a really good lecture on the ABCs of diabetes care. Pay attention.
Okay, all right, I will. Jeez.
Jeremy, put the butter down. Hello, Steve Edelman here. And today I'd like to present to you a lecture I put together called the ABCDs of type 1 diabetes. Now, this lecture we've been giving for years for people with type 2 diabetes. And it dawned on me that it is just as important for people with type 1 diabetes. So here we go. Now, first let's talk about the global issues of diabetes care because they do relate to the ABCDs. The first is prevention of diabetes, and the complications is our first goal. Obviously, we all have type 1, can't prevent type 1, but we can prevent complications. Now, the second thing is early detection of complications of diabetes. So, it's too bad that we can't go complication free our whole lives, but so they do pop up. But the earliest you can detect them, then the sooner you can start aggressive treatment of the complications of diabetes. That's it. Prevention, early detection, aggressive management. So that relates to the ABCDs of diabetes care. The D we added recently, which is drugs. And, it's really important to say up front that lifestyle modification, diet, and exercise is so important. And that's a topic of different lectures. But A is A1c. And now we're going to bring in time and range, and aspirin, blood pressure, cholesterol, and then some amazing new data on drugs that we typically use to treat type 2 diabetes that can help prevent heart attacks, strokes, and the progression of kidney disease. So I'm going to talk about that near the end. So remember that glucose control is key. And in addition to that, blood pressure and cholesterol, and they're all related to the complications you see below: eyes, kidneys, nerves, and heart. And, one of the reasons why this lecture has been so popular in the type 2 diabetes arena is because people with type 2 diabetes have a lot of cardiovascular disease. Now, it turns out, and I hate to get morbid, this is going to be a sophisticated lecture. It's not like eating 3 donuts in 15 minutes. Not like that lecture. Is that the most common cause of death in people with type 2 diabetes is cardiovascular disease. Now, just to be fair, the most common cause of death in anybody with or without diabetes is cardiovascular disease, but it's really high in people with type 2. But there's things you can do to prevent that. And it turns out that now we realize the most common cause of passing in type 1 is heart disease. So that's why this lecture is so important for people with type 1. So let's talk about the A1c. I'm not going to go through the slide in general. We all know the graphs. Your A1c is 7. It gives you kind of an average blood sugar. There it's 8, close to 200, 240, 9%. And the different graphs are different depending on where you look for them, because I believe an A1c of 7 is closer to 150. This graph says 170, but it doesn't matter. The bottom line is the A1c is an indication of our average blood sugar over the past 2 to 3 months. And your A1c, your particular A1c should be individualized. What does that mean? Most people were trying to get less than 7. It's very tough to get your A1c less than 7 if you're a type 1. But if let's say you're 80 years old and you have heart disease, we may not be as tight with you. We may say, hey, Let's try to get it less than 8. Some people less than 7.5. But for some of you zealots there that like to be less than 6, you're crazy, because that's just way too low. These ranges have been defined so that you do not develop complications over time. Now, I'm going to make a very specific point that I talk to doctors all the time. The A1c that we get from the lab is not very accurate. Why? Because you can see all the things on this slide that can make your A1c inaccurate. And you can see everything from medications to being anemic. One of the common things we see with what we call chronic kidney disease, liver disease, people taking certain supplements. African Americans have abnormal numbers, I should say not abnormal, but inaccurate. Sickle cell trait, pregnancy, alcoholism. I mean, it's amazing how many things could make this test inaccurate, including the laboratory assay method. Every hospital lab has a certain what we call assay to measure A1c. It's not very accurate. And this is an important point, that 14 to 25% of A1c values are misleading in a clinic visit. What does that mean? It means that the caregiver thinks you're under very good control when you're not, or under bad control when you're not, and may even change your medications unnecessarily. So I like to say the laboratory value reported for your hemoglobin A1c is the true estimated A1c. And on the CGM download, it has a phrase called GMI, glucose management indicator. And it's also called the estimated A1c, but it's not. It's the most accurate. So CGM average glucose over the past 90 days gives a true value of your average glucose over the last 90 days. And so it is the real A1c. And of course, your glucose values are not affected by things that affect the A1c test. Chronic kidney disease, ethnic group, pregnancy, anemia, liver disease, etc. You saw that huge list. Now is a good time to introduce the other topic that I brought up earlier, time in range. This patient here may have a good A1c, I'm not sure, but you can see the blood sugars all over the place. This is a patient of mine from many years ago, and it really shows what type 1 diabetes is like. You know, it's unpredictable swings in your glucose levels throughout the day. And remember, the A1c represents just an average. And I used to say, the best way to control my type 1 diabetes, stand perfectly still and do not eat a thing. That's true. Now, I don't say that as much anymore because now we have hybrid closed loop systems, and I'm looping with my Omnipod. There's the Control-IQ, there's the Omnipod 5 coming out. So now it doesn't have to be like that. And that's a topic of several other lectures in our video vault in the type 1 track. Now, here's the best visualization of why time and range is so important. Both those patients have an A1c of 8%. The top patient is bouncing around all over the place. Tons of highs, tons of lows. The patient below has an A1c of 8, same, but has a much better, what we call standard deviation or glycemic variability. And it turns out that time and range, the percent of time between 70 and 180, is one of the best reflections of what your A1c would be, and it relates to complications. And that's the topic of today's lecture as well. So if you look at the first line, it's all about time and range, and that's what continuous glucose monitoring has allowed us to measure. You can't do it with sporadic fingertips. You need it with lots of data, like every 5 minutes. So it turns out that, I'm spending this extra time to tell you that your 90-day average on your download from your CGM, whichever one you're using, you put that into a formula that's on the internet, and it comes up with your true A1c. And that's the most important point. So this is the classic graph that shows the goals for time and range. That green area is 70 to 180. How was that picked? Well, a lot of smart people got together and said, this is the range that you should be in including pre and post meal. And you can see the next thing that's important is time below range. 4% between 55 and 70, and less than 1% of the time below 55. And 1 hour represents 4 percentage points. So you can really go up or down depending on your glucose control. And that's important because a lot of the studies these days that we'll see and talk about, not necessarily in this lecture, it always talks about time and range and the percent of time that you are in a desirable range or not in a desirable range. Okay, so this is a CGM download just to show you, it gives you your estimated A1C. Remember, that's more accurate than the laboratory method. And then there's a mean glucose of 139, the standard deviation 46, should be less than 50. And then right here is the time and range, 73%. The goal is 70% or higher. Now, one thing to remember is when you go into the caregiver's office, they may download just the last 30 days. And it'll give you an estimated A1C, also called GMI. And then don't go crazy when that doesn't match your A1C, because that goes back 60 to 90 days. So you have to go into your own app, look at the 90-day average, and that's going to be your A1C. So remember, there's lots of good information in our video vault, and there's a great lecture I did with Dr. Schaefer-Bader, Think Like an Endo, that takes you through reading your own CGM download. Okay. That's one part of the A. It'll go faster. The A is also for aspirin. So basically, we recommend enteric coated so it doesn't cause stomach issues. 81 milligrams, that's a baby aspirin. This dose has been studied in huge studies, taking into account tens of thousands of individuals. The most famous one was the nurses study, where they studied 50,000 nurses and did a survey on those that took aspirin or didn't take aspirin, and the results were just amazing, reducing heart disease big time. Now, it's effective, it's inexpensive, of course, if you go to Costco, and it's important that you think about if you need this or not. And I'll get that to the next slide. But the way it works is it thins out your blood. Not a lot. Not like rat poison. Not like some of the stronger blood thinner medications your grandparents are on, or you may be on if you're older. It thins it out just enough to prevent clots, which leads to heart attacks and strokes. So who should be on an aspirin? Well, anybody with type 1 or type 2 if you have heart disease at any age. And it goes without saying, you got to talk to your caregiver first before you start anything. And the standard recommendation put forth by the American Diabetes Association, men and women over 50 with diabetes, type 1 or type 2, who may have increased risk for heart disease. So once again, please don't go out to the store and start taking aspirin without talking to your caregiver, because there are certain situations where you do not want to be on aspirin. It's not very common, but we just want to make sure you don't take it inappropriately. Let's talk about blood pressure. Now, if you look at the title of this slide, it helps reducing your blood pressure reduces your risk for heart attacks and strokes and helps decelerate eye and kidney disease. So high blood pressure causes those things. Reducing your blood pressure helps those things. And this is a very important area because high blood pressure is what we call in medicine as a silent killer. What does that mean? It means that your blood pressure can be pretty high, causing damage to the organs of your body. You don't feel any different. Same with cholesterol. And even it's true if your A1C is not that good. You don't feel that bad. So this is why this is so important, because if these conditions cause pain, if a little bit of elevated blood pressure caused pain, I wish it would. There would be a lot more people under control. So where should your numbers be? I can tell you, look at the green area, 120 over 80. Don't let any doctor tell you that less than 140 over 90, that area is good. That's high. And the intermediate zone is 80 to 90 to, up to 140. You can see in the yellow area. So it's really important that you get your own blood pressure cuff. Who should get their own blood pressure cuff? Blah, blah. Too early in the morning. Everybody with diabetes. You may not use it very often, but you want to get your measurements at home, not when you go to the doctor's office and the nurse is there pushing you and rushing you around and they may not be taking it correctly. You want to get your blood pressure at certain times during the day at home. And remember, blood pressure changes like airline prices and rent-a-car prices. It goes up and down. Anything can change it. And so you want to get multiple values to get kind of an average. And so I think it's way more important to get your blood pressure in your natural state than going to the doctor's office. So that's important. I know some of you are rolling your eyes. Not another device to buy. It's probably the most important device you can get other than your glucose device. And you have to learn to take your blood pressure correctly. I got these pictures off the internet and I thought this was pretty funny. If you look at the picture on the left, the cuff, the sphygmometer, that's the thing that goes over your artery that measures when you hear the pulse and when it goes away, which is how you measure blood pressure. It's way down on the bottom of her elbow. And that's not the right way to take the blood pressure. You're supposed to be sitting like the patient on the right with your arm relaxed on a table, totally supported, not just someone holding your wrist. And take a couple deep breaths, and you can see that the sphygmometer, which is right underneath that tube, is right over the brachial artery. And that's when you get the most accurate measurements. And these machines are good. You can get a wrist machine, but always remember, your blood pressure cuff needs to be at the level of your heart. And that's really important. So getting the measurement is one thing. Getting the correct measurement is another. So how do we reduce the blood pressure? Well, some of you folks out there are what we call salt sensitive, that if you eat foods that are very salty, your blood pressure will go up. And I would say this, that not everyone is salt sensitive. So this is something you could test, but I think in general, it's not good to ingest foods with tons of salt all the time. Then there's medications. Okay, really important on this list are the ACE inhibitors and the ARBs. Ready for this? Angiotensin receptor blockers. And these are drugs that protect the diabetic kidney. They've been proven and they lower the blood pressure. Now, another topic we're going to get to are the SGLT2 inhibitors. Look at that, dapagliflozin, empagliflozin. You can see I've underlined the parts of the words that show up in these drugs. Now, remember that all drugs have two names. They have generic names and brand names. These are the generic names, like their chemical structure. You don't capitalize them. And if I did, it's a typo. But the brand names are what the companies use to market them. And I'm going to talk about the SGLT2 inhibitors a little bit later in my presentation. So let's talk about cholesterol. Really important. Getting your cholesterol levels in goal. I can't tell you how important that is because that's probably the single most important thing to reduce cardiovascular disease, right alongside with blood pressure. So LDL, remember L for lousy. I'm going to talk about the numbers in a second. Then HDL, I use the word high sometimes, or healthy. You want that as high as you want. That's the protective cholesterol. Sometimes that's genetic. You have no control over it. Triglycerides are another form of fat in the blood. We want to keep that as low as possible. And it's important for you to know that your triglycerides will go up with poor glucose control. And as you improve your A1c, your triglyceride levels will come down. The other two are not directly related to glucose control. So where should your LDL be? Every single person with diabetes, type 1, type 2, should be less than 100. Now, if you've had some cardiovascular problems already, let's say you've had a heart attack, you've had a stroke, you have peripheral vascular disease, you definitely want to get less than 70. It's key. And then you have, your HDL, you want that high. Over 50 is good, less than 40 is not so good. But once again, HDL is a little tougher to budge. Believe it or not, exercise helps raise HDL, and up to 2 to 3 drinks a day will raise your HDL. Alcohol, yes, alcohol, and then triglycerides. You want to be less than 200. Less than 150 is ideal. Over 200 is too high. So you can see it's complicated, and there's different medications for each one of these categories. Now, I want to talk about statins. Probably one of the most important drugs ever discovered in medicine. And basically, we recommend that for anybody who have had a history of heart disease, anybody with your LDL above goal. I can tell you that most people over 40 are a good candidate for a statin, especially people with diabetes. And you got to really talk to your healthcare professional about it. It's key. And once again, high cholesterol, LDL, is basically an asymptomatic condition. And remember that it's really important to realize that you hear about all these crazy side effects on the internet. I would say the internet has done the biggest disservice with this class of drugs. People have said it causes Alzheimer's, it causes diabetes. What it does cause is muscle aches in certain individuals. Not excruciating muscle aches, and it occurs in about 15 to 20%. Most of those individuals, it's tolerable. Remember, this is going to save your life. So we have different methods. We take a lower dose. We take a tablet every other day because it does stay in your system. You might try a different statin, like Lovastatin, Lipitor, Simvastatin. There's all these names. And some people feel that if you take vitamin D, that could help. And a lot of people with type 1 diabetes are low in vitamin D, so that's helpful. And it's important, but not the topic of today's lecture because it would take too long. There are lots of other medications that will lower your LDL that you use in addition to a statin, or if you cannot tolerate a statin, you can take one of these, Zetia, Repatha, Proluent, Nexletol. I can tell you that I take Repatha, which is an injection every 2 weeks, with my statin and Zetia, and I have my LDL really low, and that's where my doctor wants it. So once again, please don't take your first dose of statin that your doctor gives you. It gets to about right here in your esophagus, and you develop muscle aches. It doesn't happen that fast. When people come back to see me and they have a complication with every single thing I prescribe, they're hurting themselves. So these side effects do occur, but you really have to do yourself the most favors by seeing if it really is related to the drug and seeing if you can tolerate it. Because statins will save your life, no question. Okay, let's talk about diabetes drugs. Okay, SGLT2 inhibitors. Ready for this? Dapagliflozin, canagliflozin, empagliflozin, ertugliflozin. It took me a long time to get that down. And you can see the brand names on the left. You've probably seen them on television. Farxiga, Invokana, Jardiance, and Steglatro. Now, they're all in a class, the similar class. But new data has been knocking the socks off of every cardiologist, nephrologist, and endocrinologist. This is the first time in my career we're working together because these drugs are amazing. And I'll just say this up front, and I'm going to say it again. They're not approved for people with type 1 diabetes in the United States. They are in Europe, but not in the United States. So this is why you need a conversation with your caregiver. How do they work? They work by making your kidneys filter out the glucose and put it in the urine. Now, normally, the glucose that gets filtered out by your kidney may not make it in the urine. It may be recirculated back in the blood. And you don't need that if your blood sugars are high, right? You see all those sugar cubes in that hand? That's how much your body filters out a day. So people that go on these drugs, they lose weight because you're losing calories, sugar cubes. Their A1c comes down and blood pressure gets better. And there's all the benefits. A1c Also, when they do studies with CGM in these research participants, time and range improves. People lose a little bit of weight. Blood pressure improves, which is great for your kidneys and your eyes. And they may protect your heart and may protect your kidney. Now, it's not a may in people with type 2 diabetes. But if you had a bunch of academics here, one, it'd be pretty boring. Two, they'd be dressed pretty nerdy, not like me. And three, they would not agree that this data has been clearly shown in type 1 diabetes. They're right. So this is, but many people feel that the mechanisms are going to go over into type 1 diabetes. So it's, this lecture is on the cutting edge. Now, the one thing the FDA is worried about, you see that bottom line? Euglycemic DKA, or diabetic ketoacidosis. Many of you remember that when you got diagnosed or even had a couple other episodes. Your blood sugar is high, you feel really terrible, muscle aches, nausea, and vomiting. But because of the way these drugs work and push the sugar out in the urine, you may have diabetic ketoacidosis with a fairly normal blood sugar. And that's called euglycemic DKA, and the FDA felt like it was too much of a risk because people wouldn't realize it. But with education, and with access to ketone meter, you can be on this drug very safely and know how to treat DKA at home. Fluids, insulin, carbohydrates, people forget about carbs. That helps turn off the brain's drive to produce these ketones, and test your ketones. So this is, if you had an episode of congestive heart failure, or if your kidneys aren't working 100%, please have a conversation with your kidney doctor or your endocrinologist or your primary care about this. Okay, last topic. GLP-1 receptor agonists. They have clearly been shown to reduce heart attack and strokes big time in type 2 diabetes. How do these drugs work? Well, GLP-1 is secreted upon the ingestion of food. And what does GLP-1 do? GLP-1 is a natural hormone, like insulin. It helps the pancreas secrete insulin to keep the blood sugars down. Going to the bottom right, it slows down the peristaltic motion of your stomach, so the nutrients leave the stomach slower and then do not contribute to a high post-meal blood sugar. It helps reduce your liver from producing too much glucose. And lastly, on the upper right, it induces satiety. What's that? It means that you get full faster. So these drugs are now being looked at not only to prevent heart disease, but also weight loss in higher doses. So there's all the different drugs out there. I mean, there's an oral medication called Rybelsus. There's weekly injectables that we have, Bydureon, Trulicity, Ozempic. Those are once a week. But they lower A1c tremendously. They lower weight loss, especially when used in the higher doses. They do not cause low blood sugar, same with SGLT2s. And in type 2 diabetes, there's no question that they prevent heart attacks and strokes. And it's recommended, believe it or not, that you use these drugs right after metformin. That's the typical type 2 regimen. If the patient has any evidence of what we call ASCVD, atherosclerotic cardiovascular disease. Now, have these been studied intently in type 1 diabetes? No. But many people feel they're safe, and many type 1s are on this medication, one of these GLP-1 receptor agonists, and SGLT2s, what we call off-label. And we use drugs off-label all the time as long as they're safe and effective. So, if you cannot prevent a complication, early detection is the key. And following these ABCDs are so important. So the minute you get elevated blood pressure, you treat it. The minute you see some issues in the back of your eye by your eye doctor, you want to treat it. Your cholesterol needs to be treated aggressively. These are the things that are going to prevent you from developing complications down the line. It's so important. So check out our video vault for tons of great content, no matter what type of diabetes you have. So for all of you folks out with type 1 out there, take care of yourself.